Good evening, everybody, and welcome to ICON's Facebook Live on multiple myeloma. It's great to have everyone tonight, marking what is coming towards the end of Myeloma Awareness Month that occurs in March around the world each year. Each month, ICON Cancer Centres run a Facebook Live program, and it's my privilege as ICON's Chief Medical Officer to host these programs, interviewing various specialists on different topics each month. Tonight, we have two fantastic speakers. Dr. Jason Butler, who is a clinical haematologist and colleague of mine for many years now. Jason practices at Royal Brisbane Hospital as well as ICON Cancer Centre South Brisbane and ICON Cancer Centre Chermside. Jason's got a very wide range of malignancies that he treats and clinical expertise, but has a particular interest in CAR T-cell therapy as well as treating multiple myeloma. So Jason, welcome to our Facebook Live and thank you very much for joining us.
Thank you, Ian.
Thanks. Our second speaker is Megan McDowell. Now, Megan is from Myeloma Australia, who are an absolutely fantastic organisation who provide much needed support, education, and other services to patients with multiple myeloma and their families around Australia. Megan is a specialist myeloma nurse. She has been with Myeloma Australia for a number of years, but has almost 20 years experience of working in haematology oncology. So Megan, thank you, and thank you for Myeloma Australia for being part of our Facebook Live tonight.
Thanks, Ian. Thanks for having us.
I'm Ian Irving. As well as ICON's Chief Medical Officer, I am a practicing haematologist, and I treat many patients with multiple myeloma, with that being one of the areas within haematology that I treat. So hopefully we will have a very good discussion tonight. We're going to start off that I will interview Jason and Megan, and we'll try and give a general overview of multiple myeloma. Multiple myeloma is a disease that often is very confusing, and generally patients, when they're diagnosed with the condition, have not heard of it before. Then for the second half of the evening, we're going to answer your questions. So please, through the chat function on the Facebook Live, submit your questions. We'll try to get to as many as possible. As always in these events, we definitely do not want to be giving specific medical advice. Each of us and each of you, if you are a patient with multiple myeloma, will have a specific set of circumstances that, of course, need to be treated by your personal clinician. However, in general terms, we certainly can answer your questions, and if there's anything you're wondering about with multiple myeloma, please put a question through the chat function. So I think we might get started now, and I'm going to throw a question over to Jason first. Jason, can you start off on this discussion on multiple myeloma by just explaining to our audience what is multiple myeloma? And just describe just briefly what are the different types of multiple myeloma, and even some of explaining to people some of the other different names that the condition is often referred to around the globe.
Okay, no problem at all, Ian. Thank you for that question. And look, thanks for the opportunity to speak tonight. You know, it's amazing how we can use technology these days to communicate with people in a much wider audience. It's not always easy to travel to a room and get together face to face. So that, hopefully there's a lot of people out there from regional centres who can get just as good an education about myeloma tonight as people who live in the city and close to us. Myeloma is a very difficult thing to explain, really. And I think the easiest way to explain it is to go back to the normal situation that exists in healthy people. Inside our bone marrow, and remembering our bone marrow is predominantly the factory where blood cells are made. But inside a normal bone marrow, there are a small number of cells called plasma cells. And the main role that plasma cells have in life is to make antibodies. And I think during the era of COVID and vaccinations, we learned a lot about antibodies, and people probably had never heard about an antibody, heard about antibody responses to vaccines and that. But the plasma cells in the bone marrow play a critical role in our immune defenses, so protecting us from the outside world, things like viruses and bacteria, by producing antibodies. And they are small proteins. We have billions of different types of antibodies inside us that all target a particular thing that might try to attack us. Now, what happens in myeloma is that a cancer develops within the plasma cells. So the plasma cell is the important cell that is the hallmark of myeloma. And you get a significant increase in the number of plasma cells, and they're bad plasma cells. They don't function properly inside the bone marrow. In normal circumstances, only a few percent, normally less than 5% of our bone marrow is actually made up by plasma cells. But in myeloma, by definition, that number increases beyond 10%. And often when people are first diagnosed with myeloma, that number can be 30% or beyond. And so that's sort of the basic thing that myeloma is. So it's this blood cancer that develops from these abnormal plasma cells in the bone marrow. And that those plasma cells can make abnormal antibodies in very large amounts, which is often referred to as a paraprotein or an M protein, which is often the first way that myeloma is diagnosed, when somebody turns up with an abnormally high protein level in the blood and perhaps other symptoms that make their GP concerned. There are several different types of myeloma. Most commonly, it depends upon the type of that antibody, so the abnormal protein being produced by the myeloma cells. You may hear us talking about IgG and IgA and IgM. They're some of the different types of antibodies, and the type of myeloma that people have is often labelled based on that. Some people actually can have a myeloma that doesn't produce any abnormal antibodies, and that's often referred to as non-secretory, which means that they have myeloma, but the myeloma cells don't produce those antibodies that make it easy to detect. And that's a relatively rare form of myeloma. Most of the time, myeloma will basically present with blood count abnormalities, but sometimes it can cause disease outside the bone marrow and, for example, can get into the bones. And one of the ways that people often will first turn up to, particularly their GP, is with pain somewhere, particularly in the lower back, that may end up sort of alerting the GP that is something's wrong. We often refer to this disorder as just plain myeloma, but there are a number of different terms that we use interchangeably. The real name for the disease is plasma cell myeloma, which reflects the fact that it is a disease that comes from plasma cells. The very long-standing historical name for it is multiple myeloma, and that was classically because often when the disease presented, you could find evidence of the myeloma in multiple different sites in the body. So Ian, I think I'll throw it back to you with that answer.
Oh, thank you, Jason. That's a great answer, and I'm really pleased that you finished by demystifying for people some of the discussion around the terminology. So, as you say, plasma cell myeloma is, the official name, I guess, in the classification books, but we often use the term multiple myeloma, which we abbreviate just sometimes to myeloma. Gets used a lot in medical records, I guess, to signify multiple myeloma. I know when I was training in Western Australia in haematology, there were a lot of haematologists who would use the term myelomatosis to describe the condition, and I think that's been really helpful for people, for you to reassure them that all of those terms that I've just mentioned are meaning exactly the same thing. And if one doctor refers to the condition as myeloma, that is the same disease as multiple myeloma. So, no, thank you. Throwing over to Megan now, and staying with the disease in general, but bringing it back to a human element. Megan, could you explain for people who gets multiple myeloma? How common is the disorder, and are there any known risk factors or causes of multiple myeloma?
Yeah, thanks, Ian. It's a good question, and something we often get asked on the support line when people have first found out and heard about myeloma. So myeloma in the blood cancer world, it's called a blood cancer, is the second most common blood cancer after lymphoma, which people may have heard of more commonly. But in the general population, myeloma is relatively rare. And which is why, as you mentioned at the start, it can be a bit of a shock hearing that in the doctor's office that you've got myeloma and you haven't heard of it before. Myeloma generally affects adults over the age of 65 to 70, but we also do see adults with myeloma in much younger cohorts at times. Statistically, myeloma is more common in men, and although it's not hereditary, we do see some risk factors in families and even in households. So with regards to risk factors, it would be great to be able to point to one thing that causes myeloma. We don't have a strong link for any one thing that causes myeloma. As I mentioned, increasing age can be a risk factor in itself to get myeloma. There are some chemical exposures that we know can do nasty things to the bone marrow and cause problems in the bone marrow that lead to blood and marrow cancers. And there are some populations in races where we do see a higher amount of myeloma. In Australia, there may be a higher risk factor in the Polynesian community in particular. In America, there is definitely a strong risk factor in the African American community, unfortunately.
Yeah, no, thank you. That's very helpful. And as you say, Megan, myeloma is part of the conditions that get grouped under blood cancers. So just to explain that a bit further for people, hematologists are specialist doctors who obviously specialize in blood and particularly malignant conditions of blood. And so the group of blood cancers, as you've already alluded to, Megan, includes multiple myeloma, lymphoma, and of course leukemia. And generally speaking, those conditions are treated by specialist hematologists. So-called solid tumours or solid organ cancers include breast cancer, bowel cancer, prostate cancer, lung cancer, and are generally treated by specialist medical oncologists. So, yeah, so that's just going a bit further there on the term blood cancer. As you say, Megan, when anyone is diagnosed with a serious illness, particularly a malignancy such as multiple myeloma, one of the first questions they will ask themselves and then ask their treating doctor is, why did I get this condition? What has caused my multiple myeloma? And as you have said, there often is not one particular cause. As you say, chemical exposure. There are a few risk factors. If someone does have a first-degree relative with multiple myeloma, there is a slight increased risk in that person then developing myeloma in their life, but it's not particularly high. When patients ask you, Megan, how did I get this? Why did I get this? On a personal level, explaining the disease to them, how do you go about answering that question for them?
Yeah, it is. I mean, it is like I said, it's a common question of the why and the how, and usually we can't give a good answer to the why and how the myeloma came about, but we can arm our community with information on what to expect going forward. So we believe at Myeloma Australia that information is power, and it helps the community to advocate against themselves, and also to have a bit better understanding of what to expect and what questions will be helpful to ask at their next appointment.
Yes. No, thank you. That makes perfect sense, and I think is very helpful to people to be looking forward. And I as a treating hematologist, and I'm sure Jason agrees, education, knowledge is power, and the more knowledge that patients, carers, and family have, the better. The days of people being kept in the dark about particular conditions, are certainly, hopefully, long gone. So, no, thank you for emphasising that. Going back to Jason now, let's stay with the concept of a person who is being recently diagnosed with multiple myeloma, and Jason alluded to some of the ways in which patients with multiple myeloma can be diagnosed and present, whether it's abnormal blood test and a paraprotein being found, or having a pathological fracture, or back pain, or various other symptoms. But Jason, once someone is diagnosed with multiple myeloma, do you want to step us through, as a clinical hematologist, how you approach that patient, what tests you order, and why, and how do you prepare someone for that point where they're ready to commence anti-myeloma therapy?
Yeah, absolutely, Ian. And again, just reflecting on what we were talking about just then, often when people come up for a diagnosis of myeloma, in many people it could often be the first interaction with medical specialists. Often this can be a diagnosis that comes out of nowhere in otherwise very healthy people. So we're not just confronted with a situation with somebody who is being told they've got myeloma, but also somebody who's really seeing doctors and nurses potentially for the first time in their life, and that can be a very scary experience. And certainly one of the things that we try to do is to make what is very significant changing life event actually into one that we can sort of help people get through as best as they can. So I mean, often when people referred along to us as hematologists, they've often seen their GPs over the previous few weeks, maybe 2 or 3 times. Often the way that somebody goes along to see their GP initially can be with a symptom that takes a little while to actually nut out whether it's significant or not, and actually coming up with the idea that this may be myeloma will sometimes take a GP 2 or 3 visits to actually finally come up with that suspicion. And so more often than not, when somebody gets referred to us, it's not with a confirmed diagnosis. It's really with this suspicion, either based on the changes in the blood tests or investigations that have been done on an area of pain that has revealed what may be myeloma. And so, as we were talking about before, given the basic underlying problem that happens is inside the bone marrow, one of the important tests that almost always will need to be done is a bone marrow test. And in fact, many of the medications that we access these days, because they're often very costly medications from a government's perspective, pleasingly, the government funds many medications and means that the price from a patient's perspective is that of just a normal script that you would pay for antibiotics. But actually, because of the cost involved, actually demonstrating to the government that that particular person has myeloma, having proof, is actually really important. So it's not just to get the right diagnosis, but it also informs all of the decisions and treatments that we can access later on down the track. Bone marrow tests have a fearsome reputation, I think, for the majority of people, because of the ability to give people sedation or medications to help with pain at the time. A bone marrow test is usually nowhere near as an unpleasant an experience as people often think it's going to be. The sample's normally taken from the back of the hip bone. It's a very safe area, and the procedure itself takes about 5 minutes. So it's actually a relatively straightforward test. It's certainly not a test you'd prefer to have done if you didn't need it, but it is critical to make that final diagnosis. And it normally takes 2 or 3 days for the final results from the bone marrow test to come back, and that would normally be the way that we prove the diagnosis. In the meantime, while the bone marrow test is getting done, we also organise for some additional blood tests done that can look at things like kidney function, which can be affected by myeloma, as well as some blood counts as well. One of the other features of myeloma can be changes in the blood counts, particularly the red cells. So in some patients, they can be anemic because of the myeloma. And I guess the third important test that gets done are scans. So that can range from old-fashioned, low-dose, non-contrast CAT scans. So very safe. There's very little radiation with the type of scans that we need to do, and there's no contrast dyes. And we can basically use those CAT scans to image every single one of the long bones in the body, looking to see if there's any evidence of myeloma in any of those bones. So that will include the spine, the upper arms, the upper legs, the pelvis, and the skull as well. In addition to that particular test, some people will have an MRI scanners done as well. Sometimes that's a very focused MRI that looks just, for example, at the lower back and the pelvis, which often in myeloma, if there's going to be any evidence of bone involvement from the myeloma, it's likely to be in that area. So we'll often combine that very wide-ranging CT scan with a more focused MRI scan as well. So all of those tests will be organised, pretty much at that first visit in anybody where we suspect the likely diagnosis is going to be myeloma.
No, thank you, Jason, and thank you for emphasising to people watching that a bone marrow examination should not be a traumatic experience anymore. And as you say, with sedation that we often use, or other medications and adequate local anaesthetic as well, it should be a very small and well-tolerated procedure. No, thank you. So, patient has undergone their tests, and you've explained that beautifully about we have blood tests and urine tests, we have scans, we have the bone marrow. How is myeloma treated initially? Now, thankfully, the survival, of course, with multiple myeloma is improving, and in the 25 years since I started doing haematology as a haematologist, the average survival with multiple myeloma has gone from what was that long ago 2 to 3 years to now well over 10 years, and that's an average, and a large number of people are surviving for even much longer than the average. So in some ways it's a good news story, and therefore there's a long, complex journey that one goes through with multiple myeloma, and often many lines of therapy. But just honing in on the therapy at the start, what are the important principles of how to start a patient on anti-myeloma therapy, and what treatment should someone receive initially?
I guess, Ian, there's a couple of components to that. Probably most importantly for everybody in the room, so the way that we manage myeloma is often determined by what we have access to, and also what is funded. As I mentioned, a lot of these treatments can be very expensive, and the sequence in which we're able to use these medications, and I think at the moment we probably have access to about 6 different lines of therapy, so 6 different styles of therapy. But in fact, in the frontline setting, really, there's only a couple of different treatment options that are funded by the government. Now, that's okay, because those treatments are not, they're not inferior treatments. They're what would be considered fairly much gold standard treatments for the management of myeloma. Those treatments no longer really involve any chemotherapy, at least initially. They are combinations of targeted therapies. We're able to now put together a couple of different relatively new targeted therapies. So one of those is a treatment called bortezomib, and another is a treatment called lenalidomide. So for the majority of patients, particularly those who are reasonably young, reasonably fit. Now, reasonably young probably means often sort of up until people's early 80s, as long as they're healthy enough to attend the clinic on a reasonably frequent basis, often sort of once a week. And if they're geographically located in an area where they can easily get access to a day hospital, then a combination of bortezomib and lenalidomide with steroids as a triple therapy, so combining 3 different drugs, would be the way to go. Now, in frailer people or people who are in their late 80s or mid to late 80s, or for people whom the ability to travel up to the hospital is not so easy, we can often use just the lenalidomide and the steroids by themselves, and that in itself is also a very effective regimen. We, as part of that frontline thoughts about patients, if somebody is again young and fit and they have good overall organ function, we do think in the very early stages about whether somebody would be a candidate or eligible for a stem cell transplant, which in itself is a very lengthy discussion. But right from the time that we first meet somebody, even once we get just the first treatment started, we're already sort of thinking about what may be the next line of things that we're going to be thinking about.
Yeah, no, thank you. And that's that mention of stem cell transplantation is a great segue into what I was going to ask you next, and what actually some of our audience are already putting through in questions on the chat. And for everyone, if you do have any questions, please put them through on the chat function, and we'll try to address as many as we can. So as you're saying, Jason, induction therapy is started. Often it's 3 drugs: Velcade, bortezomib, lenalidomide, dexamethasone, if patients are able to withstand it, as you've said. And you're thinking about the next step, and in many patients you're thinking about proceeding to an autologous transplant. Do you just want to explain to people 2 things, really? Firstly, who is eligible for an autologous transplant, and is there an upper age limit for an autologous transplant? And that question's come through from a couple of different people on the chat. And then secondly, maybe explain to people what is involved in going through an autologous transplant.
So answering the first question, most centres won't have a specific age limit. It will be more based on an individual fitness. So in some ways, what we would describe as biological age rather than chronological age. So how well somebody is. So a well and fit 75, 76-year-old could certainly still be eligible for a stem cell transplant. The reason why it's an important decision is that a stem cell transplant is quite different to that initial type of treatment we use. It goes back to old-fashioned chemotherapy, but it's chemotherapy given at a very high dose. And it's a dose of chemotherapy that really is very toxic to somebody's bone marrow function. And so the process is one of collecting and storing some bone marrow stem cells, first of all. And that happens as the first step. And then the second step that occurs a number of weeks later, you come into hospital and you get a very large dose of chemotherapy. And then we give the stem cells back to essentially rescue the person from that really large dose of chemotherapy, particularly their bone marrow. Now, it takes a while for all of that to actually right itself. So after the stem cells are given back, it's another 10 to 12 days before those stem cells work their way back into the person's bone marrow and starting to make brand new blood cells. And so during that time, a person will have around 5 or 6 days of no bone marrow function at all. And what that means is the risk of infections and fevers is very high during that time. And in fact, almost everybody who goes through the transplant process will end up on very strong antibiotics because of fevers and infections. And it can have a lot of effects on the gut in particular. So nausea and abdominal pain, diarrhea, and those sort of symptoms are very common. And even in a very fit, healthy person, it can take up to 3 months to recover fully from a transplant. So the reason why we do have to be a little bit selective in working out who can undertake a transplant or not is because of that intensity of the transplant process. So I would normally not recommend the majority of people over the age of 75, unless they were still running marathons or that, to actually undergo a transplant process. That's partly because I think the benefits of the transplant on the myeloma are well and truly outweighed by the risks and side effects of the transplant. But also because we are lucky enough to have a lot of different treatment options. So even if we said, look, forget about the transplant, we believe that we've got so many treatment options available that in reality, that person really loses nothing by not undergoing the transplant.
Yeah. Thank you, Jason. That's fantastic, and I'm really glad that you've given the advice to everyone watching, that chronological age is not everything, and biological age and how healthy you are is actually more important. There are a couple of recent papers in the literature over the last few years looking at transplanting older patients. There was out of the ABM TRR, hematologist at St Vincent's in Sydney, who wrote a paper on looking at the Australians over 70 who were transplanted with multiple myeloma, and it was found to be very feasible. At Icon Cancer Centre, we had Dr. Karthik Nath, a previous fellow of ours, who published a report on almost 2,000 transplants that were performed at Icon centres, and it included actually quite a substantial number of patients over the age of 70 who had no inferior outcomes, so compared with younger patients. So if patients are properly selected, as you've said, Jason, there's no absolute upper age limit to undergo a transplant. Megan, let's go back to you now, and let's think about, we've got patients, their carers, their families on treatment for multiple myeloma. They're on a journey, and we know that through any cancer journey, and multiple myeloma is no exception, there will be ups and downs and various hurdles to cross. What advice do you give to patients as they progress through anti-myeloma therapy? What should they be doing with diet, exercise, work, management of medications, etc.?
Yeah, thanks, Ian. And that's a really good, I just wanted to point out Jason's comments on transplant, and that really fits into the questions that you're asking, Ian. That is, we really have to look at a whole person, not their age and not their gender, and find out the individual needs of that person in a myeloma journey. We hope for it to be a long journey with myeloma. So initially, when we speak to our members or someone that's made their first contact with us, it can be really overwhelming learning all of the information. We've just touched on it tonight on a few topics. There's so much information to take on board. And usually the general theme from our members is how to take control and how to feel like you've got some input into your journey. There's a book that's written by a doctor in America who actually found out he had myeloma, and I use a quote from his book quite often, is that you need to be the captain of your ship when you have myeloma. And in saying that, you have to employ a really good crew to run the ship. And to run the ship, you have your haematologist would be in the engine room, making sure that everything's ticking along. And then you've got a whole lot of other crew doing all the other functions of the ship. But at the end of the day, none of that team can function too well without the information from the captain of how the ship's travelling. So with regards to if you're not eating well and you're losing weight, then we need to employ a dietitian. We know that exercise is really important during cancer therapy, but also for carers and loved ones to maintain good mental health and physical health, to maintain this, like I've mentioned, hopefully a long journey. So Myeloma Australia can offer a navigation through that to help you find out what that individual need is. And the way that you can engage with that is through our myeloma support line. We have a myeloma support line that runs Monday to Friday business hours. It's 1-800-MYELOMA, so it's easy to remember. And you can speak to a specialist myeloma nurse like myself. We have nurses situated all around the country, and they can give you local knowledge. We can direct you if you're living in Victoria or Western Australia. We can direct you to local services to help what your individual needs are.
Thank you, Megan. You mentioned exercise and the importance of exercise, which I wholeheartedly support. Well, could we just perhaps expand a bit on this topic of exercise whilst undergoing cancer therapy? What are there specific types of exercise that are more beneficial than others, and what sort of specific advice around the exercise do you and the other specialist myeloma nurses give to patients?
Yeah, also a really good question. There's a lot of research going into the benefits of exercise, particularly in myeloma. And there is Professor Tina Skinner is actually in the process of publishing a lot of that data, who's an exercise physiologist out of University of Queensland. And you can look that up as a MyEx study. And that was to try and show the benefits of weight-bearing exercise in myeloma patients. So we know that bone health is really important for people living with myeloma, and that there is a lot of fear around patients who may have had fractures or may have had lesions where they feel frail, and maybe it would be too dangerous to participate in a weight-bearing exercise program. But we know with the guidance of the approval of your treating team and with the guidance of an exercise physiologist that weight-bearing exercise is not only safe but really beneficial to increase the osteoblast activity. So those are the cells that make bone cells. One of the exercise physiologists explained to me that if you think of the muscle that's attached to here and here on your bones, and if you increase the weight-bearing exercise of that muscle, it's going to tell the bones here and there that those areas need to strengthen up. And you can imagine why that's quite important in myeloma, that we want really strong, healthy bones where possible. But it is important that you do this safely. So I must reiterate that you need to be talking with your treating haematologist, and then seeking out a good exercise physiologist, which can be covered by Medicare with a GP chronic disease management plan. And Myeloma Australia can talk you through that if you have any questions about that.
It's a very good point, Megan, about the importance of exercise therapists, exercise physiologists, physiotherapists also often have a role to play here. You mentioned dietitians before. Now you've spoken about the importance of exercise. Perhaps now, could I ask you about what sort of diet should someone on treatment for multiple myeloma follow? I think all the patients I see are bombarded with lots of advice from their family and friends about all sorts of diets, and some of them are, shall we say, rather esoteric. And then there are, of course, all sorts of natural supplements and apricot kernels and curcumin and various other things that certain well-wishers will recommend to a patient to take. But when you and your specialist colleagues are talking to patients, what specific advice are you giving patients around diet?
Yeah, so another really good point, Ian, and I know you and Jason would get these questions a lot, and we certainly do as well. The restrictive diets are really common, and adding in supplements and certain types of like I mentioned, restrictive diets I think they come from a place from patients wanting to, once again, find control in an uncontrollable situation. So although we don't want to discourage someone seeking their own other pathways for supporting your treatment, it's really important that you disclose if you've found something that you'd like to try or something that you'd like to add to your treatment regime that you've found outside of your treating team at the hospital. It's really important to disclose that to your pharmacist or your doctor, because not everything that's natural is safe. So you mentioned apricot kernels, which are full of arsenic, and there's Agent Orange and mustard gas. All the chemotherapies that we use today have all come from natural plant-based proteins. So they can be really powerful and can be dangerous if taken in conjunction with some myeloma therapies. I'm sure a lot of your listeners today know that green tea and the grapefruit can have effects not on how the bortezomib works and how your clotting factors work. So diet on adding in things is important to disclose. With regards to what a healthy diet that we would recommend with myeloma, it's coming back to finding out what's missing and how can we just support a normal healthy diet. And that's where speaking to a dietitian of back to that individual, what's going to suit you and work it with your lifestyle to support your needs. So we can certainly navigate how to refer to a dietitian if you've got more questions on maybe what your electrolytes are and what you're missing, if there's anything that we can add in your diet to support you. But all with communication, back to that teamwork. We want to do it as a team and share our decisions together so that we can navigate it safely.
No, really well answered, and thank you, Megan. And I very much do like the analogy of being the ship's captain as a patient, and we absolutely, as hematologists, we want to encourage patients to be in control of their own journey and be the captain of the ship. But as you say, sometimes things are not as easily controlled as just one particular type of diet or restricting something, and it's more complex than that. Now, going back, we've had a few questions come in now through the chat, and please continue to put your questions through the chat. I'm going to lift a few questions from the chat and throw to Jason first of all. We've got a question from Beck around CAR T cells, Jason. In particular, the question being, are CAR T cells available in Australia to treat multiple myeloma? But perhaps you could preface the answer to that question with a brief education for us and the listeners about what CAR T cell therapy actually involves.
Yeah, no problems, Ian. Look, I've been lucky enough to have been involved in a number of clinical trials now of CAR T therapy in a number of diseases, but particularly myeloma. So really the way we think treatments are moving forward in myeloma really are involving harnessing the effects of the immune system. And CAR T technology is one of those. So basically what happens with CAR T cells is that inside our cells, inside our bodies, we have lymphocytes, which are important immune cells. One of the subsets of lymphocytes are T lymphocytes or T cells, and T cells do a lot of things. They can act as the generals of the immune system, but they can also act as the infantry. They can walk up to whatever's attacking us and try to beat it into a pulp. And others almost act like spies and sort of grab snippets of information from whatever's attacking us and take it back to those generals who coordinate the overall attack. So these T cells are really, really important defense mechanisms inside us. So in CAR T therapy, what we do is we collect T cells from the person. It's a very similar process to how we collect stem cells, except there's no injections, there's no chemotherapy. So we just collect the T cells. And those cells then get sent off, and they get, at the moment, in the example of myeloma, they would go off to the United States. There's a couple of different companies that have this technology and are involved in manufacturing CAR Ts. Now, what then happens in the US, these T cells are modified, so they're re-engineered, and they have a target that recognizes a protein on the outside of myeloma cells inserted into them. And then they get, then they're allowed to grow and expand, and then they get frozen down, and then they get sent back to us. So basically what's happened is that we have re-engineered our own immune system to specifically target myeloma cells. There's not a single protein that can be used. There's a common one at the moment called BCMA, and that the first generation of CAR Ts target this thing called BCMA. So when they come back, the person goes through some really gentle chemotherapy, and then they receive an infusion of these CAR T cells. Now, what happens then is those CAR Ts recognize the myeloma cells and basically attack and kill them. And it's a bit of a self-fulfilling prophecy, because as the CAR Ts attack the myeloma cells, it activates them and it causes them to expand. So the binding to the myeloma cells actually cause more CAR Ts to be produced, which is quite a remarkable thing. Now, incredibly high response rates in the early studies, in patients who'd had more, on average 6 lines of different myeloma therapy. The number of patients getting into very deep response was 98%. So nothing like anything we've seen before. The downside was that the responses in those early studies didn't appear to be long lasting. But in the context of how advanced the myeloma patients were in that study, and perhaps there was a group of people where life expectancy maybe have been no more than a few months at most, average life expectancy or average time before their myeloma progressed was in the order of 18 months. So it was probably 10 times greater than they would have expected without the CAR T therapy. So incredibly high response rates. But the one chink in the armor is that the myeloma in the majority of patients still seem to come back, but with quite good quality of life in between times. The main problems with CAR T therapy is that there are some side effects. Because of the activation of the immune system, you can get a lot of problems with fevers being generated by the inflammation, and there's a very rare there's a problem where you can get quite confused and delirious due to a problem where a lot of the inflammatory chemicals can get across from the blood into the brain. Now, there's ways of treating all of those. So overwhelmingly, people who get side effects from CAR T treatment, the treatments that we use, turn it back off again. And so the period in hospital is about 10 to 14 days. And people, I notice a question in the chat about comparison with an autologous transplant, so a stem cell transplant. Broadly speaking, it's a much better tolerated treatment. So there probably are people for whom an auto transplant couldn't be done, but would be well and truly robust enough to undergo CAR T therapy. Is it available in Australia at the moment? No, not outside of clinical trials. So at the moment, there's a process that a number of committees are considering about the funding of CAR T treatment. It's very expensive. The cost of CAR T treatment is somewhere between probably about $300,000 and $500,000 just for the actual re-engineering process. And that doesn't include the cost of the other treatments and that. So that's the reason why it's a tricky situation in a country like Australia, where the government funds these treatments, and having a finite pool of resources, that there's going to have to be a lot of to and fro and sort of decisions around costs and that before we'll have access to it in the commercial space. At the moment, the only clinical trials in Australia are actually in the frontline setting. So it's actually moved forward to the point where we're now looking at comparing an auto transplant versus CAR T treatment in young fit patients and seeing whether there's a difference. And we do have a trial at the Royal Brisbane in newly diagnosed people, again, where you get CAR T treatment as part of frontline treatment in people who are not considered suitable for a transplant. So it's where we're at the moment. So I agree with everybody. It's certainly not ideal at the moment, but there's very valid reasons why at this point in time we don't have access to it routinely.
Yeah. Thank you, Jason. That's been very comprehensive answer. Another of the very modern therapies to treat multiple myeloma are so-called BiTE antibodies. We've had a few questions, including one from Melissa, that have come in around wanting to ask, are BiTE antibodies available to treat multiple myeloma? And how do BiTE antibodies compare against CAR T cell therapy in the efficacy of treatment for multiple myeloma?
So just to explain, and again, BiTE antibodies are another type of immune therapy. The difference with BiTE antibodies is that rather than taking away somebody's immune cells and sending them off to be re-engineered, BiTE antibodies sort of almost re-engineer the immune system inside the person. So basically, a BiTE antibody has two bits to it. One bit attaches to the myeloma cell, so it targets the myeloma, and the other part of it attaches to the T cells, so the very same cells that we send off for CAR T manufacturing. And what it basically does, the BiTE forces the myeloma cell and our T cells up against each other, and basically tells our T cell to attack and kill the myeloma cell. So it's a similar concept, but just a different way of going about it. The main distinction is that BiTE antibodies need to be given on a regular basis. So there are some of them that have to continue forever. There are others that have a limited frame. But unlike CAR T treatment, which is sort of a one and done kind of treatment, the BiTE antibodies are given sort of over a more extended time. Which is better? We actually don't know the answer to that. So the early data from the BiTE studies also looks really, really good. So perhaps even similar response rates to what we see in CAR T treatments. And again, like with CAR T treatments, there's a number of potential proteins that BiTEs can target. So it's not necessarily it has to be one or the other. Particularly in the US at the moment, they are looking at sequencing, perhaps giving people CAR T treatment and then studying BiTEs, or the other way around. It will be a similar sort of argument, though, that these treatments are very expensive, and the side effect profile is perhaps similar to what we see with CAR T. So it's that similar problem of fevers and confusion that complicated that can be complications, but again, normally respond very well to treatment. So it remains to be seen which one will be better, but we anticipate that in fact both will probably end up in the clinical space down the track.
Thank you, Jason. That's very helpful, and it is a very exciting field at the moment. Multiple myeloma, as you've outlined, lots of new treatments, lots of new immune therapies, hopefully coming online sooner rather than later. We had another question come in from Ross that I'll answer quickly, relating to allogeneic stem cell transplantation for multiple myeloma. And Ross, I think you are spot on in in saying that allogeneic stem cell transplantation for multiple myeloma is being used less and less often these days. It's not a very common way of treating multiple myeloma, and allogeneic stem cell transplant has significant toxicities and in general is not used very often at all. There are certain circumstances, and plasma cell leukemia is one example in a younger patient where an allogeneic stem cell transplant can be used, but you're quite right that the sort of therapies Jason has spoken about, BiTE antibodies, CAR T cells, and some of the newer anti-myeloma drugs generally are preferred over allogeneic stem cell transplants. Another question had come in around the genetic risk, and unfortunately we had a comment from a patient about being diagnosed with multiple myeloma after their husband had also had the condition. I think that is an unusual and sad situation. That is a statistical anomaly. I don't think if someone is diagnosed with myeloma after their spouse also having the condition, we could postulate a common cause. As we had mentioned at the start of the broadcast, there's a slight increased risk in someone developing multiple myeloma if a first-degree relative, for example, a parent, has had the condition. However, it's only a very slightly increased risk, and it doesn't mean that if someone is diagnosed with multiple myeloma, you need to go out and automatically check all the other relatives, the children and siblings for the condition. Megan, I'll just throw another question back to you, and I'd love you, if you could, to comment on the psychological support that is required to be given to a multiple myeloma patient, and maybe you could expand on the important steps that you recommend patients and their carers take so that they maintain their psychological health in going through what we all hope is a very long journey with multiple myeloma.
Yeah, that's a really tough one to talk on. Psychological support is complex, and there are lots of ways that you can seek professional psychological support depending on where you are in your treatment journey. So at lots of different time points, we find we get a kind of uptake in calls when people are seeking support for their myeloma journey. Obviously, when people are first diagnosed with myeloma, we often see people either calling our support line or attending one of our online support groups, or we're soon to be going back to face-to-face support groups. We know that the power of peer support is phenomenal. If you can feel brave enough to join in and meet other people with myeloma, it can take the sting out of some of that loneliness. Like we mentioned before, myeloma is relatively rare, so it's unlikely that you'll have too many people in your circle that knows a lot about myeloma and what you're experiencing. So sometimes talking to people that you don't know too well, but you have a common condition, can really take the load off talking to your loved ones all the time. We know that carers take a big brunt of the psychological burden as well. So we welcome carers coming along to our groups and calling our support line. And we found that to be really powerful. We know that there is online groups. There's a big Facebook community of myeloma members, which is really active and healthy, and that's a space generally kept just for patients so that they've got that safe space to vent and talk about their frustrations and also their happy times, and talking about the travel, the trips they've travelled around Australia while on treatment, which can be really uplifting and bring a lot of hope to other people. So sharing your burden is really important and really powerful. When it gets beyond that and you're feeling more frustration, that's when it's good to talk to your treating team as well about how you're coping, and maybe you need some more professional guidance on how to navigate and keep that one foot in front of the other. So once again, communication is key with your treating team. It's really important not to be stoic and just put up with it. We find that a lot with people feeling that fear of if I talk to my doctor about it, they may take me off this treatment or restrict access to treatment, and that's certainly not the case. It helps your treating team decide on the best pathway forward, and thankfully, like Ian Jason mentioned, we've got a lot of options now in myeloma, and if one pathway is not working, we can certainly talk about finding another pathway. So I suppose just recapping that, peer support through organisations like Myeloma Australia and Leukemia Foundation, one-on-one support through our support line, and keeping the communication flowing between you and your treating team and your general practitioner, of course.
Yes. Thank you, Megan, and mentioning the very important, indeed pivotal role that general practitioners play in patients' medical care is a great way to finish the evening. I'll now draw the session to a close. Thank you everyone for tuning in. There will be a recording of tonight's Facebook Live on the Icon Cancer Centre Facebook page. We've now got quite a collection of our Facebook Live events that we've done on various topics over the last few years, and we very much encourage you to go back and watch the recording, or indeed, of course, share the links and the knowledge that these recordings are there with your fellow patients, carers, loved ones, friends, etc. So thank you for tuning in, and please I direct you to the website and Icon's Facebook page to be able to look at further viewings of tonight's recording. Lastly, but very importantly, again, a big thank you to Dr. Jason Butler, Icon Haematologist at South Brisbane and Chermside, and to Megan McDowell, Specialist Myeloma Nurse from Myeloma Australia. You've both been fantastic, and we very much appreciate you coming in and sharing your knowledge and wisdom tonight. So thank you again to Jason, Megan, and also, of course, our communications team at Icon, who put together all the technology that seems to work reasonably well to put tonight's event on.
Been a pleasure. Thank you.
Thanks, Ian.
Thank you, and good night, everyone.